My name is Erica and I'm from WAC, and we're going to go through HIV under the microscope today. So my hope is for you guys to take away from this bite the knowledge of the 7 stages of the HIV life cycle. So that's HIV in the body and how it's attacking the immune system, and also the 9 types of antiretroviral treatment that are available, and just a little bit about how they work. So we've got a bit more of a deeper understanding about what's going on inside the body. So before I go any further, I'm just going to hope that my slides work. There we go. Just do an acknowledgement of country. So I would like to acknowledge the Whadjuk people of the Noongar Nation, where I'm meeting on today, where I'm sitting today. They're the first and true custodians of the land on which I'm sitting today. And I pay respects to the elders past, present and emerging. Their immutable strength and resilience, and also something that inspires me is their beautiful connection to country, and it's something that I take time every day to think about as well. So I invite you guys to maybe during this presentation right now, or maybe a little bit later on, have a little think about what your connection to country might be wherever you're from, and think of maybe 1 or 2 things that really give you a shiver and make you feel like you're at home. So just want to acknowledge that as well. All right, guys, so a little bit about WAC. I'm not going to spend too long on this because, again, I'm mindful of time, but just wanted to let you guys know of WAC and put up a kind of a little overview there of all of our services and the way that we provide support to the community. Primarily, we started off as AIDS support back in the 1980s, and now we've grown into basically a sexual health service and education service and health promotion service and harm reduction service for people who inject drugs. We've also got an amazing in-test counselling and case management team for people that live with HIV. We've got peer education. We've got wonderful regional projects for young people who identify as LGBTIQA+. We've got our M Clinic and we've got our Freedom Centre, and you can visit our website to find out more about all of those services there, or you feel free to ask me any questions at the end as well. But that's where I'm from, and I'm part of the yellow arrow at the bottom, training resources and support for sexual health education and capacity building, so within the workforce development section. And this is my job, to come and do workforce development trainings, and I'm really pleased to be in connection with Aqua and Hepatitis WA to bringing birds and BBV bites to you guys. All right, let's jump straight in. So I'm just going to go a brief overview of HIV. I'm sure that we've all got a sort of a basic understanding of HIV and what it stands for, but I'm just going to go through that again within the context of this presentation. So HIV stands for Human Immunodeficiency Virus, and obviously as it's uploaded into Teams there, it's kind of all squished in a little bit, so I do apologise if you couple of the structural things there. We can work on that for next time. So human immunodeficiency virus basically means, broken down, that it needs human beings to survive and to replicate. Immunodeficiency means that it's attacking the immune system, and we're going to talk more about this in detail. And a virus is the smallest living organism. And then I've got this wonderful GIF, this wonderful little moving image for you guys, just to start getting you prepared for the concepts that we're going to be talking about today. So this wider, larger, big pink circle with the blue kind of dotted circle in the middle, this is denoting or depicting a Cd4 cell, also known as a T lymphocyte or a T helper cell. It's actually also a white blood cell. So this cell in this picture here, the Cd4 cell, is one of the main components of our immune system, and this is the very type of cell that HIV uses, basically uses to replicate itself inside the body. So if you're having a look at this little moving image here, this is pretty much exactly on a really base level is what's happening inside the body with HIV, and the little green circles there they've also got a pink outline there, that's depicting HIV. So HIV comes along, attaches itself to the outside of the Cd4 cell, implicates itself inside the cell, replicates, and then basically gets out of the cell again. So we're going to look at that in a little bit more detail. And we've got a little bit of a magic number to bear in mind. I'll go on with this one first. So what I've got here, I actually created these. I'm quite proud of these. So we've got a bit more of an in-depth depiction of a Cd4 cell and an HIV cell. So we'll go to the Cd4 cell first. A couple of things I want you to note that's going to help you to sort of understand this on a deeper level is the little green receptors. They're called receptors on the outside of the cell. So as you can see, they're like little stems with this kind of, they're depicted with this kind of little bowl on them. So we know they're known as receptors. And then I want to draw your attention to the inside of what I've tried to draw of the nucleus. And you can see inside the nucleus there the DNA strand. And I'm sure we can all remember, hopefully back to high school biology, where we're talking about cells and nucleuses or nuclei and those DNA strands. So those 2 sets of DNA strands that we've got there. And then if you pop over to the HIV cell, you'll see on the outside of the HIV cell, they're not quite receptors, they're more like they've got these little buds within them. And as you can see, if we move that HIV cell a little bit close to the Cd4 cell, they might just fit in there exactly. And it's called docking. So what happens is HIV sort of docks. There's little receptors on the outside of HIV, and that docks into the receptors of the Cd4 cell. And if you look into the center of the nucleus of HIV there, you can see that there's actually a single strand within the nucleus. And this is what's known as an RNA. So you've got a DNA in your Cd4 cell, and you've got an RNA within your HIV cell. Moving through to the next slide, we're just going to break down HIV even further, just to kind of help, because what we're going to do is then apply this to the stages of the HIV life cycle, and this is all going to start to make sense as we talk about it in terms of treatment as well. So we've broken down that HIV cell, and you can see those little buds around the outside of the HIV cell, and then we've got the sort of the outside of the cell underneath the buds is also known as the envelope, and then you can look inside the cell of HIV, and there's the RNA that I was talking about, that single strand. And then we've got a capsid. Basically, it's like a container where all of these things, the RNA sits, and the HIV enzymes sit within that capsid, or that little bowl. You can think of it like a bowl. So these are terms, again, that hopefully we'll be able to send out the slides, or if you want to email me, I can email you this picture. These terms aren't necessarily things that we always have to remember, but it's just cool to have a look at and put some words to going into that deeper level of what's going on in HIV, inside HIV. So moving through to the next slide, and just at the top there, I've got my HIV, and there's our magic number that I was mentioning earlier. So our magic number is 7. So there are 7 stages to the HIV life cycle. So we're going to look at this HIV cell in more detail now as we go through the 7 stages of our HIV life cycle. So our first stage is known as binding. So this is the bit that I've already kind of described to you guys. It's where the HIV cell comes in contact with the Cd4 cell. And as you can see, those little buds there are fitting directly into that Cd4 receptor on the outside of the cell, and they're binding in. The second stage after binding is that there are a couple of proteins that are involved here, but actually HIV utilizes to insert itself through the outer shell of Cd4. So you can see there that HIV, after binding, it kind of breaks through the layer, the first layer or the shell of the Cd4 cell, and see that capsid that we were talking about, the little bowl that had some enzymes and some proteins and the RNA in it. You can see that that bowl then sort of starts to float into the Cd4 cell, and all those things start to become a little bit free inside the Cd4 cell. Got a third stage here known as reverse transcription. So anybody that is familiar with HIV medication already, you might have heard of reverse transcriptase, which is used in a form. It's a form of ART or HIV medication, and that's what in this third stage is what's happening. So as you can see here, we've got the inside of the Cd4 cell. That capsid or that bowl has become free, or the insides of that bowl have become free within the Cd4 cell, and you've got that RNA, and it goes through a process called reverse transcription or reverse transcriptase, and turns itself into DNA. So that's one of the parts of our life cycle that we need medication to interrupt. And as you can see, once it's become HIV DNA, it's moving closer and closer to the nucleus of the Cd4, so the real center of the Cd4 cell. And then moving through to the next slide, we've got our fourth stage, which is integration. So that HIV RNA that's now gone through reverse transcription and has become HIV DNA is now actually able to get through the cell, the nucleus of the Cd4 cell. So you can see here you've got the Cd4 cell nucleus, and then you've got some of those proteins that came out of that capsid are following that HIV DNA into the nucleus of the Cd4 cell. And then you can see there at the bottom of that diagram, you've got that Cd4 cell DNA. Remember those 2 strands that I had drawn in my little diagram. So the HIV DNA actually uses more proteins to bind itself into the DNA of the Cd4 cell. So it sort of becomes part of the DNA of the Cd4 cell. And that's why HIV is so clever and at times so scary, because it does all of these stages, and at every stage is actually quite an amazing feat of science that it's able to do this. So HIV then inserts itself into the DNA of the Cd4 cell. Our fifth stage is called replication. So what then happens is that there are certain proteins and certain cells used to once HIV has the HIV DNA has inserted itself into the Cd4 cell DNA, it starts to replicate itself. So you can see that there's HIV proteins, and it replicates itself not quite as that strand of DNA, it replicates proteins, and these proteins are then going to help HIV move through to its 6th stage. And these proteins travel back through the CD4 cell, back through to the surface of the CD4 cell. And as you can see, there's an HIV shell starting to form on the outside of the CD4 cell. And so more HIV RNA and HIV proteins are basically a new capsid, or a new bowl is being developed as it reaches to the outside of that CD4 cell. So they can see how that new HIV particle is being created then. And as we move through that 7th and final stage, it's known as budding. So those proteins and those HIV proteins that we saw, the green wiggly bits, and then the RNA that's sort of coming out there at the of the CD4 cell. Once it's fully out of the CD4 cell, then that capsid starts to form completely. And there's other proteins, and you can see their protease there. It's actually known as immature HIV. So it's not able to replicate itself just yet. It's just come out of that CD4 cell, and it uses protease and other proteins to basically develop into mature HIV once it's outside of that CD4 cell. So that's our 7th stage after budding. Takes a little bit of time once it's outside of the CD4 cell, and there you are. It's outside of the CD4 cell. We've got our mature HIV, and then that mature HIV cell plods along in the body and goes off and finds another CD4 cell, and that process happens all over again. So when a person is infected with HIV, that's what's happening in their body all the time. And that's why you might have heard things like the CD4 cell count is really important to monitor in somebody that's living with HIV. Also, viral load is really important to monitor in someone that's living with HIV. And that's because the more that the HIV cells are able to do this to CD4 cells, they eventually, and we'll talk about this a little bit in more detail later, they eventually destroy the CD4 cell. So that's why your CD4 cell count starts to come down, and that's why when HIV is allowed to be in the body untreated for a long time, so if HIV goes untreated in the body for a long time, attacking those cells of the immune system, those CD4 cells, that count starts to drop below a normal or an average amount, and that's when people can develop AIDS, because our immune system has just been so depleted by HIV using those CD4 cells to replicate. And just to kind of, I like a little bit of repetition because it does help us to remember things. I've actually just got a more simplified drawing of those 7 stages there with the numbers next to it of that life cycle, and with the edge of the CD4 cell just in view there as well. So just drawing your attention to 1, binding, 2, fusion, 3, reverse transcription, 4, integration, 5, replication, 6, assembly, and then 7, budding. Okay. So then we're going to go through those 7 stages and talk a little bit about ART. So ART is known as antiretroviral treatment. So just to explain that a little bit, because not everybody always understands, where did it get its name from? Why is HIV medication known as antiretroviral treatment? Well, if you take your memory back to that reverse transcription stage, so the 3rd stage of the HIV life cycle, the RNA becoming the DNA is actually reversing something. So what's happening there? It's actually taking something that's happening in the CD4 cell and it's reversing it. So when a virus does that, that's what's known as a retrovirus. And so obviously our medication, our HIV medication, is we've titled that antiretroviral treatment, because a lot of the there's 2 main types of ART that actually attack or actually prevent that reverse transcription happening, but then the other forms of ART that we'll go through briefly actually support the stopping or the pausing or the halting of that reverse transcription as well. So that's our antiretroviral treatment. Other things to remember about antiretroviral treatment is it's a lifelong medication. So it's not a cure for HIV, but it's a very, very, very successful treatment. And those levels that I was talking about, the CD4 cell levels that start to come down because HIV is attacking and replicating inside the CD4 cells, the treatment actually stops that, protects the CD4 cell, stops that from happening, and the CD4 cells are able to start growing and replicating as themselves again. And that means that that viral load is coming down, because HIV isn't able to replicate inside the body, and so HIV cells are then dying off and unable to replicate, which means the viral load then comes down. Now, the higher the CD4 cell count and the lower the viral load, the better in someone that's living with HIV. I'm pressing my key arrows and not my Teams arrows. So magic number 9 when we're talking about ART, types of ART. Now, some of these names are really long and you don't have to always remember all of them, but I do have a diagram that actually puts all 9 types onto that HIV life cycle, so you can kind of get an idea about what's happening. So we'll just go through them briefly. Number 1 is those nucleoside reverse transcriptase inhibitors, also known as NRTIs. We've also got non-nucleoside reverse transcriptase inhibitors, it should be double N RTIs. So those two are the main types that actually come in that third stage and pause or halt or disenable HIV from being able to go through that third stage of reverse transcription. Then we've got protease inhibitors. You would have seen protease a couple of times through that life cycle, because protease is one of the main proteins inside HIV. We've got fusion inhibitors, remembering the stage of fusion. This is a type that comes in at that stage and actually prevents fusion from happening, so the HIV from fusing into the Cd4 cell. We've got Ccr5 antagonists. So Ccr5 is also like a protein or an enzyme that's involved in that life cycle, and antagonist just means the sort of the opposite of. So it's not in line with, it's reversing, or it's on the opposite of, so it's coming in and attacking it on the other side. We've got number 6 is integrase strand transfer inhibitors, so INSTIS. And we've got attachment inhibitors. We've got post-attachment inhibitors, and then we've got pharmacokinetic enhancers. So don't worry about remembering all of those big terms, but they're just there, especially if this might be the first time that you're seeing this. It's just nice to have that broken down and kind of start to become a little bit more aware of some of these words, because if you're working with anybody that may be living with HIV, or working with someone that may be a family member or living with someone of HIV, these terms are going to come up in the types of medication that they either hopefully are going to be on, or maybe already living, taking. So going through that life cycle once more, remembering that simplified diagram that I showed you, and then we're going to go through and put these 9 types of treatment into the stages, above the stages or next to the stages, just so you can see where they actually come in there. So we've got our Ccr5 antagonists and our post-attachment inhibitors over that first stage there. Then we've got our fusion inhibitors there, preventing the fusion of the HIV cell into the Cd4 cell. Then we've got our NRTIs and our NNRTIs there above that reverse transcription phase, so the third phase. We've got integrase strand transfer inhibitors here, so it actually inhibits the integration, remember, of once our HIV RNA has changed into DNA, and then it gets into the nucleus and actually inserts itself into the Cd4 cell DNA. So that's what that type of medication is helping to prevent. And then over here on the 7th stage, under budding, we've got our protease inhibitors, so that prevents immature HIV from becoming mature HIV. And then we've actually got, drawing your attention back to number 1 there, I don't know whether the order went a bit skew there. We've got our attachment inhibitors sitting up over the first section as well. And then our pharmacokinetic enhancers sit outside here, because the pharmacokinetic enhancers are actually just a medication that helps to enhance the other parts of ART. So that's not something that actually jumps in and affects any of that 7 stages. It actually just helps to enhance the others while they're doing their job. So hopefully this gives you a little bit more of an idea of all of the stages and all of the amazing things that we've been able to achieve in HIV medication and what could be going on inside the body. Now, just to clarify at this stage that somebody isn't on all 9 of these at one point. So ART is generally a combination of 2 or 3 medications. Normally it's 3 medications, and they'll be chosen from the different for the different stages, depending on the person's body, any other co-infections that that person might be living with. So for example, if they're living with hepatitis B or C, some forms of ART actually help to manage or treat hepatitis B and C. So it sort of depends on where that person is at, depends on their liver function, depends on their kidney function, depends on their viral load, how long they may have been living with HIV. So that's why it's really important to see an S100 prescriber. So that means a doctor that's had specialised training in prescribing HIV treatment. GPs without this training can't actually prescribe ART because there is a lot involved in how we work out what treatment regimen is best for a particular person. So, and what we'll normally find as well is that sometimes people might go on a particular regimen and then they think, oh, you know, there's some side effects, or I'm just not feeling it, or perhaps my viral load isn't getting as low as it could be. So there's within a controlled environment, doctors with S100 prescribers and specialists can work with that person and go, okay, well, we might give you a different fusion inhibitor, or we'll give you a Ccr5 antagonist instead of a post-attachment inhibitor or something like that. So there's a lot of combinations out there, and this is just the tip of the iceberg of those long and sometimes overwhelming names. So moving on now through, I'll draw your attention back to our Cd4 cell, and I told you I was going to talk about this a little bit later on. So we're going to get that image back again. That I just love my GIF. I think it's the best, simplest way of explaining what's happening inside the body. Now, our HIV can infect our Cd4 cell in 3 different ways. So that cycle happens in 3 different ways. So a Cd4 cell can be abortively infected. That means HIV can go through those first 2 stages, get inside the Cd4 cell, and then something about the proteins or the way that cell's feeling on that day prohibits HIV from actually going through any of the later 5 stages. So it doesn't replicate. It's just not happening. So that's what's known as abortively infected. So some of the cells can be infected in this way. Productively infected means the HIV cell has come into the Cd4 cell and is able to go through all 7 stages of its life cycle, which means that Cd4 cell has successfully been recruited to help HIV replicate. So that's productively infected. It's productive, it's happening. And then number 3 is latently infected, which means HIV has been able to integrate itself into the Cd4 cell and go all the way to that 4th stage, but something is preventing the 5th, 6th, 7th stages from happening. So the Cd4 cell is infected and it's alive. It's there. HIV is there. It's just not able to replicate itself and get that 7th stage happening, so that budding stage happening, and actually get out of the cell. And so this is why ART is so important, because the abortively infected cells doesn't really matter. That cell has been infected and then it's unfortunately just become, it's either died or it's just nothing's really happening there. Productively infected and latently infected, however, is really important to have that HIV medication, so that ART. So not only does it stop those productively infected cells, but it's important to be on that lifelong treatment of medication, because the latently infected cells are also a bit of a worry for us, because HIV is actually alive, living. The Cd4 cell is alive and living. It's just not producing, and at any point that can change. So something that there's lots of theories as to why, but that can be triggered. That latent cell can be triggered and it can start producing again. So that's one of the reasons why ART, it's so important to not only start ART as soon as possible, but also stay on it for the length of your lifetime. And the as soon as possible is because we want to get as little latently infected cells as possible. So that's why even if somebody feels completely well, it's really beneficial to get them into a healthcare provider, a specialist that they feel connected to, and that's really going to respect their journey and help them to get onto a medication regimen that's going to work best for them as soon as possible, because we want to prevent not only those Cd4 cells being productively infected, but also latently infected and having them sort of sitting there and not doing anything, and then maybe wreaking havoc on the body and the immune system later down the track. All right, and then to kind of round this all off, I've got a diagram of, so if you can see here, this yellow line is indicated by HIV and the red line is indicated by CD4. So right at the beginning of the chart, when the yellow line is right at the bottom and our CD4 cell is between 550 and 1,400 cells, that's a within a normal range. And then as you can see, the yellow line comes in and that's indicating an HIV infection. And what happens is it spikes up and you can see that viral load going up and down through the lifespan of somebody as they're living with HIV untreated. And then, so just to give you an idea of numbers and CD4 cells and viral load that we talked about at the beginning, our CD4 cells can, in a healthy person, is anywhere between 550 and 1,400. And if a body becomes infected with HIV, we're talking about over 1 million copies per milliliter of blood, so it's about a teaspoon. So it can really, really grow, and it can really, really use those CD4 cells to replicate. And that's another reason why ART is so important. And then what happens through the lifespan is our bodies are really clever, and CD4 does get a little bit of a handle on HIV. As you can see, the red line starts to come up a little bit. Again, remembering this is untreated, and our viral load comes back down again. And we kind of live with HIV slowly increasing over the years, and CD4 cells slowly decreasing over the years. And as you can see at the bottom here, I've got a place on this chart where I've indicated that CD4 is at 200 cells or less per cubic millimeter in the body. So that's really, really low. And that's unfortunately basically a state of when a doctor can diagnose a state of AIDS. So that 200 is really, really low. We don't want it to get that low ever. So another reason why we need to start ART and why it's so important. And then you can see in this next part of the chart after ART is started. So even though the CD4 cells are so low, this person can still start ART, and that CD4 cell count is able to grow and climb again. And you can see it's almost reached the point at where it was before the person became infected with HIV. And you can see that viral load started to decline there. And actually 200 is a bit of a magic number to remember in terms of CD4 and HIV, because that viral load now has become down to less than 200 copies per milliliter of blood. So thinking about going from 1 million and over to less than 200 copies per milliliter of blood. That's a massive, massive difference. And the amazing thing about this magic number of 200 is once we get that viral load, so then the copies of HIV within the milliliter of blood, once we reach that viral load underneath 200, that's when we're technically considered undetectable. And the amazing thing about that is there's not actually enough virus in our blood to transmit to somebody else sexually or vertically. And we're making headway on studies into direct injection into the blood as well, and for now that's still a little bit in contention, but there's not been any cases of anybody transmitting HIV, so we're hopeful that the CDC is also going to name that as negligible or impossible as well. So yeah, that's what's really exciting about our U=U message, and that's basically what's behind that message is undetectable is untransmissible, and that's what undetectable means, is that viral load has been brought down due to ART being able to stop HIV at one of its 7 stages of replication inside the body. So we're just going to go through, I'm going to show you my U=U message. They're really, really important to still spread that message. And hopefully this presentation has given you a bit more of an understanding, because something we're finding is U=U is a pretty easy thing to say, but maybe not always everybody is understanding what exactly U=U means. So hopefully this presentation has helped out sort of bust a few myths or kind of get things a little bit clearer inside your head, or even how to talk to other people about it as well. That really important U=U message. And I've looked at the clock. I've got 3 minutes left. Does anybody have any questions to ask about all of the information I've just put out?
I do.
Yay!
So if you're a doctor and you're working in a remote area and you want to treat a patient that's been diagnosed with HIV and you don't have the training, what do you do?
ASHM is a really good place to start. ASHM has an amazing array of online trainings that they're normally like workforce development, so for people that are already S100 prescribed. But you can contact WAC, or I would be contacting ASHM to find out what trainings are available to you, especially now with online training. I know ASHM do a lot of great online trainings as well. So, and we're wanting to really improve, or further improve, because we've done a really great job in Australia with our strategy in response to HIV, and we're just wanting to improve that all of the time. So I dare say there would be things that are very cost effective, if not free, to become an S100 prescriber, particularly in regional or remote areas. So you can contact WAC at any time, or you can go to the ASHM website, so that's ASHM, and they have a lot of online trainings that you can access for free as well.
Okay, now that's good. I think it's important because we're really encouraging, as part of an STI screen, that you include bloods for syphilis and HIV.
Yeah.
So if we're going to be, testing a lot for HIV, I think really it probably is a matter of time before HIV, comes into communities. And I know it's happening already in other states. Yeah. So yeah, it's just really good to know. A lot of services have a lot of change of staff, a lot of locums coming in. So perhaps, you know, I guess in preparation, it's an idea to sort of have that on the agenda, that there be someone in the service who is able to give HIV medication.
Absolutely. Yeah, I completely agree with you. And that's one of, you know, and that's even a whole other discussion or topic that we can actually do even for birds and BBB vites, is talking about barriers to healthcare, barriers to treatment adherence, because treatment adherence is something that we're really passionate about. And that's actually in the new strategy now. Instead of 90, 90, 90, it's now 95, 95, 95, 95. There's a fourth kind of addition at the end as well, is that people that are on treatment have quality of life. So yes, a barrier is absolutely having access to an S100 prescriber or a specialist, an HIV specialist. But also then once you're on the treatment as well, how do we adhere to that? And there's lots of barriers to that too, in terms of housing, access back to the town or the place that had the S100 prescriber or the specialist resides. Yeah, it's a travel, cost, that sort of thing. So there's definitely massive gaps in that. And I think, like you said, just in that terms of preparation, if we're going from a preventative model of healthcare, definitely getting the word out there to get people educated in S100 prescribers is a definite great step.
So treatment is free?
Yes, they've actually passed it. When was it? It was only about a month ago or something. They've actually made it free for any, and I don't think you have to have a Medicare card either. It's just something that we want to do Australia wide, and WA just jumped on. I think they were already doing it in other states, and WA just jumped on that as well. So as part of their global response to HIV as well, because it's not just about Australia, as we know, and we can. And again, statistics is something else that I can possibly create a presentation around too. But globally, there's just so many issues and so much I can't think of the word, it's injustice, but there's so much inequity with access to treatment across the globe, and in terms of which country you live in, and access to healthcare with that too. So as part of a global response, a lot of countries that can have jumped on to give HIV treatment for free for people that need it, because it's in all of our best interest to give that treatment to as many people as possible.
Okay. Was there any other questions from people out there? No. All right.
No problem, everybody. Well, you can always email us or write something through. Oh, thank you so much, Shannon. Oh, great. I look forward to seeing you on here in future as well. Thank you. No problem, Sarah. Thanks so much. And yeah, you can keep in touch with us, and please feel free to. I've actually just remembered I've got a form here. Oh no, I'll just get it up for you again. Otherwise, we can email it through, I'm sure, Veronica.
Yeah. All right. Well, thanks, everybody. It's 12:33, so we've gone over the bite time. I will keep in touch with you guys, because we've got some great ideas for some more bites. So I look forward to seeing you all again soon. I'll get another flyer made up with some links and some more topics. And please email me with any topics that you would like, and I will also investigate getting a guest speaker, or maybe if I can do it myself, I will. So
great. And look, I've just put the feedback form in there. It's a Microsoft form, so if anybody is still around and could fill that out for us, it'd be really, really helpful. Evaluation is always so helpful with anything like this, so if you could take the time to fill it out, that would be great. Thank you.
All right. Thanks, everyone.
See ya.
Enjoy your weekend.